Muchas gracias. Buenos días. I will take the opportunity that there is simultaneous translation so that I will make a short introduction in Spanish. No está mal introducir a Peter Anderson en español, puesto que ahora vive en Palamós, una ciudad al norte de Barcelona. Quiero dar las gracias a toda la organización, especialmente a Pablo y a Nicolás, por todo lo que han hecho. Como vicepresidente de Inebria creo que debo reconocerlo, y por darme la oportunidad de estar ahora aquí introduciendo la Nick Heather's Lecture. Para aquellos que no lo conocen, Nick Heather es un psicólogo que reside en Newcastle y que tiene una larguísima trayectoria en el campo de las intervenciones breves. Peter Anderson probablemente es de las pocas personas que le pueden disputar a Nick en esa trayectoria. Pocas personas hay en el mundo que tengan una trayectoria tan extensa, tan dilatada como la de Peter en el ámbito de las intervenciones breves. Peter hablará de un report que escribió en 1986 y de allí seguirá el hilo. Un hilo que seguramente no va a mencionar, pero sí me gusta mencionarlo a mí, la gran cantidad de proyectos en los que ha estado involucrado, casi siempre liderándolos, desde entonces hasta ahora. Fase 3 de la OMS, fase 4 de la OMS, estudios colaborativos, proyecto PEPA, Ánfora, Odin, Alisrap y ahora Scala. Son algunos de los muchísimos proyectos en los que ha estado involucrado durante esos 30 años. Me gusta poder introducir a Peter porque creo que es desde, ahora discutíamos si era 1992 o 93, cuando nos conocimos. En ese momento yo llevaba un tiempo colaborando con la Dirección General de Drogas. Aquí está el que todavía es su director, que es Joan Colom. Y Joan me dijo: Tony, vamos a hacer algo en serio con el alcohol. ¿Qué tenemos que hacer? Y yo le dije: vamos a hablar con Peter Anderson. Y entonces ahí nació una larguísima colaboración que todavía dura. Colaboración que además ha dado paso a una amistad que me honra y que me da todavía más placer poder presentar a Peter. Peter tiene fama de muy trabajador, muy organizado, y solo una persona con las ideas bien amuebladas en la cabeza y tan trabajador como él puede tener una línea de trabajo tan extensa y tan provechosa como ha tenido hasta ahora. Pero ese Peter que lleva muchos años en el terreno no es un Peter acomodado, no es un Peter que se repite, sino que vamos a tener la oportunidad de escuchar a un Peter revolucionario. Nos va a contar Peter una visión de toda esa trayectoria que, lejos de entrar en el conformismo, cuestiona lo que hasta aquí muchos dan por sentado. Y, por tanto, para mí es un placer, no me enrollo más y le doy la palabra a Peter para que nos deleite con su intervención. Muchas gracias.
Thank you, Tony, for those words. I don't really deserve any of them, but thank you anyway. I want to very much thank the Inebria Organising Committee for inviting me to give the Nick Heather lecture. I really don't think I can give Nick the justice in my lecture, but I will certainly try my best. I would also very much like to thank the government departments of Chile, SENDA, and the Ministry of Health for their help and logistic help and support in getting me here. So thank you very much for that. I must admit I also had a slight ulterior motive. I have a nephew who is an astronomer and who works at the Paranao Observatory north in the Atacama Desert. So actually I went there on Tuesday to spend the night with him. He actually runs they have 4 telescopes there, he runs this one. This observatory is probably one of the most, I would say, famous and best optical observatories in the world. And it's been famous for many reasons, but a year ago, for example, there was a detection of what's called a gravitational wave. This was predicted by Einstein's theory of general relativity. And in the United States, the LIGO detector network detected this gravitational wave, and immediately they put out a signal to everyone, try and find out where this is coming from. And this is very sensitive. And the Paranal Observatory managed to find the location of two neutron stars that were colliding 130 million light years away, and this is the photo of it that they took. So also congratulations, I think, to Chile for hosting this observatory. It really is something for those interested in this topic that's making a huge contribution to science. Okay, so I'm going to talk about a report that was made by the Royal College of General Practitioners in the United Kingdom 30 years ago, asking the question, where are we 30 years on? I should declare my prejudices. I was a co-author of this report. Exactly at the same time, Paul Wallace, who's sitting in the audience here, was involved in a similar report by the Royal College of Psychiatrists, and it was interesting working together on that. I should also say that I am, by training, a general practitioner, a primary healthcare physician from the United Kingdom. I'm also, by training, a specialist in public health medicine from the United Kingdom, and both of those trainings and clinical experiences very much dictate my views around alcohol. The report was called A Balanced View. It is balanced because it was neither for alcohol nor against alcohol. Its goal, though, was to reduce the harm done by alcohol. It also used the term balance frequently, recognizing that there was a balance between the advantages of drinking and the disadvantages of drinking that determined where an individual lied on the continuum of consumption and harm. There was also a balance in terms of the pressures to drink more, often coming from society, and the pressures to drink less, and that again determined where an individual lied on the continuum of consumption and harm. The report made it very clear that the role of the general practitioner or the primary healthcare physician was to shift the balance from heavier drinking to lighter drinking. So we're going to examine the report and think, what does it say for us today, 30 years later? I'm going to look at the balance between simplicity and complexity and make the argument that I think we've gone much too far in the direction of complexity when discussing this topic, and we need to shift, this is very sensitive, we need to shift the balance back towards simplicity. Rebalancing to simplicity will allow the balance to be maintained with one area of increased complexity. So in other words, in my presentation, we're going to do away with 4 things, and we're going to add 1 thing. We're going to look at these 5 things that are all covered in the report. So whilst what I say may well seem rather kind of radical or even strange, I suppose, to many in the audience, these are what was actually said in this report 30 years ago. The 5 things we're going to go through are, first, there are no dichotomies, no diseases, only continua. Alcohol is the risk factor. We need to measure alcohol consumption. We need only to give simple advice to cut down on drinking. And we need to provide a lot of community support to community agents being primary healthcare, doctors, nurses, social workers, and others. So let's start off with the first topic. There are no dichotomies, no diseases, only continua. This is what it said in the report. We do not subscribe to the view that alcoholism is in itself a disease. I think we can update that terminology to say we do not subscribe to the view that alcoholism, alcohol abuse, alcohol use disorder, alcohol dependence are in themselves diseases. Instead, everyone's drinking is spread along a continuum from one end with no harm to another end with great harm. Let's try and explain this in a little bit more detail. In medical settings, and indeed often in academic and lay settings, heavy users of alcohol are commonly dichotomized into those with an alcohol use disorder or those with not. However, we should remember that alcohol use disorder is a clinical construct that is often used as a shorthand to identify individuals who might benefit from advice or treatment. But as a condition in itself, it is a medical artifact which occurs in all grades of severity with no natural distinction between health and disease and no grounding in biology or nature. If we look at the distribution of alcohol consumption, and this is data from 86,000 adults in the UK, where you've got the frequency or the number of people and the grams of alcohol per week along the horizontal axis, you see that the distribution is log-normally distributed, skewed towards heavy drinking. But the line is a smooth line. There's no sudden kind of blip up at the end where you might expect people with alcohol dependence. I don't know how to turn that off. I'll just push it away. There's no blip there's no blip at the high end where you might expect people with alcohol use disorder or alcohol dependence to lie. Also, when we look at the disease risk, again, it's a continuous relationship, often exponential. Here's the risk of liver cirrhosis in terms of standard drinks per day, and you see it's a smooth line getting steeper, going up steeper as the alcohol consumption goes up more heavily. But of course, unmanaged heavy drinking can be associated with even further heavy drinking, often culminating in a more difficult to manage state due to associated brain atrophy. But the brain atrophy is a consequence of the heavy drinking. I'll show 2 slides to illustrate this. This is data from the Framingham study that looks at the relationship between drinking levels and brain volume. On the horizontal axis, you've got drinking levels ranging from abstainers through to high consumption, and on the vertical axis, thank you. So that's better. On the vertical axis, you've got brain volume, and basically you see as consumption goes up along the horizontal axis, brain volume goes down. And then this is a study looking at the impact of brain volume on time to relapse in people that were treated with alcohol dependence. You've got the time to relapse on the horizontal axis. On the vertical axis, you've got the proportion of the people without relapse, and then each of the curves, each of the lines goes down in brain volume. So the top orange line is higher brain volume, the bottom mauve line is lower brain volume. So the people that have more damaged brains, that is lower brain volume, relapse much more quickly than the people who have less damaged brain, i.e. their volume is more normal. As we know, alcohol dependence and alcohol use disorder is simply defined as a checklist, as a score on a checklist of symptoms. You ask people questions. If they answer yes to that question, you give them a score, and you add up the score. That's what alcohol dependence is, or alcohol use disorder is, nothing more. And there is a smooth line relationship between levels of alcohol consumption and the score on that checklist. I'm using here Audit C scores as a surrogate measure of alcohol consumption. I mean, they correlate very highly. So you've got Audit C score across the horizontal axis as a measure of alcohol consumption. You've got the mean number of criteria of alcohol use disorder on the vertical axis, and you can see as alcohol consumption goes up for both men and women, the number of criteria goes up. It's a smooth line, slightly exponential relationship. And it's exactly the same if you look at alcohol dependence. You get, again, a smooth line going up between the amount of alcohol consumed and the probability of dependence. So I would argue that alcohol, and it's not just me, many other people have argued, that alcohol use disorder is a diagnostic artifact, and no more is needed to consider what is called alcohol use disorder other than the amount of alcohol consumed. Thus, the first simplification, terms like alcohol dependence, alcohol use disorder, alcohol abuse are not useful. So let's simplify them and simply do away with them. We only need the term alcohol use. We'll now go on to the second of the 5 points, that alcohol is a risk factor that exists on a continuum, it causes harm on a continuum, and has no risk-free level. This is data from a pooling of all sorts of studies that looked at about 600,000 current drinkers from 83 prospective studies and followed them up. And what you can see is that this is the hazard ratio of all-cause mortality by alcohol consumption in terms of grams per week. The reference category are people that drink between 0 and 25 grams per week, and you can see that the risk of death stays fairly flat up until about 100 grams, and thereafter increases exponentially, showing that how above at least 100 grams, any increase in consumption increases the risk of premature death. They also, I'm very sorry, this is so sensitive. They also looked very nicely at the years of life lost by age for people with different drinking categories, this time using the reference category, someone drinking between 0 and 100 grams of alcohol per week. And as you can see, they took 3 categories, people drinking 100 to 200, people drinking 200 to 350, and people drinking 350 or more grams per week. And if we take the higher categories in green, so those people drinking about 5 drinks a day, if you're a 40-year-old man, you will lose 5 years of your life if you go on drinking that amount. If you're a 40-year-old woman, you'll lose about 4.5 years of your life if you go on drinking that amount. This is a very nice way to show how powerful alcohol is as a toxic substance in reducing life expectancy. Of course, it's not just alcohol on its own that is the risk factor. There are other confounders, and I will mention 3. The first most important confounder is socioeconomic status. This is linked cohort data from Scotland, looking at the relationship between units of alcohol or drinks of alcohol per week in relation to the probability of an event, those events being either deaths or hospitalizations. And in each slide, you've got people in the sort of more browny color of quotes, lower socioeconomic status, people in the more blue color of quotes, higher economic status. And they did this with deprivation scores. I can't really read this from here. What is this one? Education? Sorry, manual labor, non-manual labor, thank you. People with low education, high education, people with low household income, and people with high household income. And you can see for the same level of alcohol consumption, everyone who is in a, quotes, lower socioeconomic group were more likely to suffer an event or death from their drinking. A second important confounder is our certain genetic traits. For example, there is the genetic trait that affects the alcohol dehydrogenase enzyme, the enzyme that converts or that metabolizes alcohol to alcohol dehydrogenase. Those people that have an enzyme defect tend to get high levels of alcohol, high levels of alcohol dehydrogenase in their blood, and that causes risks of increased certain diseases. This is the example of esophageal cancer, and we find that at all levels of alcohol consumption and at the same level of consumption, people with the genotype are more likely to get esophageal cancer than people without the genotype. So that's another confounder. The third one I want to mention is the presence of people who have alcohol use disorder or alcohol dependence, because if this was a true condition, you would expect maybe at the same level of alcohol consumption, people with that condition to have a higher risk of death. This is data following up studies of US Army personnel. It looked at the hazard ratio, the risk of death on the vertical axis in relation to the drinks per week on the horizontal axis. And in the first run, the presence or absence of alcohol use disorder was not included in any of the models. And in the blue line, you can see how the risk of death goes up with increasing alcohol consumption. Then they added into their model whether or not alcohol use disorder was present or absent. And when they did this, basically the line was very similar. A slight drop-off maybe at the higher levels of consumption, but this was not a statistically significant difference. You might argue, well, maybe alcohol use disorder presence is a confounding variable. But the problem with this study, and in fact there have been 3 similar studies, and it's the same with all of them, is that they looked at categories of drinking. They did not look at drinking as a continuous variable. And I'm going to set Jürgen a challenge in a minute, because this is data from the US National Interview Survey, looking at the levels of alcohol consumption in different drinking categories by whether people had, quotes, no alcohol dependence or, quotes, alcohol dependence. And everyone that, quotes, had alcohol dependence within a drinking category had higher levels of consumption. Jürgen, you must have continuous data and presence or absence of alcohol dependence perhaps sitting on your computer. And maybe by the end of the presentation, you can answer this with looking at continuous rather than categorical data. Okay, there's also been a fashion to use phrases such as harmful use of alcohol and unhealthy alcohol use. If you look at the definitions of what these terms mean, though, harmful is fraught with. It means it increases harm or injury. It's injurious, it's hurtful. It's actually having the quality of causing hurt or injury. And unhealthy is also hurtful to health. Now, as any alcohol has the attribute of causing harm, the terms harmful and unhealthy are redundant. And again, we just need to use the term use of alcohol. So the second simplification is we do not need terms like harmful alcohol use, unhealthy alcohol use. So let's simplify and also do away with them. We only need the term use of alcohol, which exists on a continuum, increases harm with increasing consumption, and can easily be measured. Which comes on to the third of the 5 points. All that we need to do is measure alcohol consumption. And we are measuring. We are not screening. And this is really important to get over. So something like the Audit C is actually a measurement instrument. People use it as a screening instrument. That is incorrect. We're measuring, we are not screening. Screening can be defined, I'm going to have to come down the aisles, I can't read it. Screening can be defined as the presumptive identification of unrecognized disease or defect by the application of tests, examinations, or other procedures which can be applied rapidly. Screening tests sort out apparently well persons who probably have a disease from those who probably do not. But as we have done away with terms, conditions, and diseases, there can be no screening. We are measuring alcohol consumption as one measures blood pressure and blood glucose levels. Thus, I would argue that SBI or SBIRT is no longer the correct term. It should be MBI or MBIRT, measurement and brief advice, or measurement and brief advice, sorry, measurement, brief intervention, and referral for treatment. But the I in MBI is also wrong, as M, measurement, is also an intervention. There have been many studies that have demonstrated this. One of the best ones was actually by Jim McCambridge, who looked at the impact of just asking questions about alcohol on changes in reductions of consumption. It didn't here quite get to statistical significance, but you can see very clearly that just asking about alcohol consumption has an impact on someone's drinking. It's pretty obvious because you're raising awareness, you're raising the sensitivity of it. So therefore, I would say we need to replace the I, intervention, for advice, because measurement is also part of the I, and then we come down to MBA or MBART, and that's a bit complicated, so later on we'll get rid of the RT. That comes later. Okay, as I said, the role of the GP is to shift the balance in favor of lighter drinking. So what are the thresholds of drinking for a response? I think there's a continuum of thresholds. We can have a prevention model, we can have what I call the standard audit C model, or we can have the audit C model based on the blood pressure model. So the prevention model is very easy. Don't drink more than 100 grams a week, ever. Don't drink more than 14 grams a day, ever. It probably is lower than that, but at least this one is we got good evidence of this one. And this comes back to the years of life lost. Even for people that are drinking between 100 to 200 grams a week, they lose about half a year life lost at the age of 40 if they go on drinking that amount. The standard audit C model is using a cutoff score of 5. If you look at the relationship between that cutoff score and the number of drinks per day, that's equivalent to actually about 20 grams a day, so quite low, if you like. And in a way, this is also a prevention model. So that's what people commonly do. I'm going to be in favor of the hypertension model based on the results of randomized controlled trials. In hypertension, in blood pressure, levels of blood pressure that are chosen as thresholds for advice and pharmacological treatment are determined by randomized controlled trials. Basically, you ask the question, at what threshold level does advice lead to a meaningful reduction in blood pressure? So we can do the same for alcohol. At what threshold level does advice lead to a meaningful reduction in alcohol consumption? Sorry. Need to be more delicate. This was Eileen Kayner's 2007 Cochrane review that had 29 trials, had a baseline consumption of 330 grams per week. So the average consumption of people entering into the study was 313 grams per week, 45 grams of alcohol per day, and this led to a reduction between intervention and control groups of 38 grams per week. So I would argue that this is our cutoff point, 45 grams, our threshold, 45 grams a day. I'm sorry. 45 grams a day is roughly equivalent to an audit C-score of 8. So I'm arguing that we should use audit C-score 8 as the threshold for giving advice. Now, you may ask, why did I use Eileen's 2007 Cochrane review and not her 2018 Cochrane review, which has just come out? Well, for two reasons. The first reason is the trial settings. In the 2007 Cochrane review, 24 of the 29 trials were in general practice or primary healthcare settings. Whereas in the more recent review, that proportion was much lower. It was only 38 out of 69 trials. In fact, 27 of the trials in the updated Cochrane review were in emergency care settings. And there's an enormous difference in outcome between those settings. So the original review on the left, the reduction was 38 grams between the intervention and control group. In the new review for the GP settings, it was 26 grams per week, but for the emergency setting, it was much lower, only 10 grams per week. So that's one reason why I used the 2007 review. The second reason is the baseline consumption level. In the original review, it was 313 grams per week. In the new review, it came way down to 183 grams per week. And what is interesting, really, is that, is that if you look at the consumption level at baseline on the horizontal axis, as that consumption level goes up, then the mean difference between the control and the intervention groups comes down. So if you start off with a higher level of consumption, you will get a bigger impact between your intervention and your control group. But also, this mostly explains why you find a difference in outcome by year of publication. So if year of publication goes up, the difference between your control and intervention groups goes down. And that's largely because the newer studies there's two reasons. The newer studies are looking at lower levels of consumption to begin with, and they also have a lot more emergency care trials in them, which has lower outcomes than general practice trials. So I'm arguing that the threshold for advice should be 45 grams a day, equivalent to an audit C-score of 8. At that level, you have the same cutoff score for men and women. In fact, at that consumption level, men are at higher risk of losing years of life than are women. They lose more years of life than do women. In fact, all of the epidemiology shows that at any given level of consumption, men are worse off than women, which is contrary to what we always used to think. So, the third message is simplifying. We are measuring alcohol use, Audit C being a useful instrument. The threshold for brief advice based on trial results would be Audit C of 8, same for men and women, equivalent to about 45 grams of alcohol per day. On to number 4 of my 5 points, the simplicity of advice to cut down on drinking. Paul, you need to concentrate on this one. This is Paul Wallace's diagram. This was in the report of the Royal College of General Practitioners. In those days when Paul and I were practicing GPs, this was our prescription pad on which you wrote your medical prescription. And Paul said, well, drinking is exactly the same. Your treatment is cut down on your drinking. And I actually argue probably that's all you need to do. I don't think you need to do much more than that. The point being is that when you look at the intensity of the intervention, you do not gain anything by doing longer or more intensive interventions. This is looking at trials of brief advice compared to controls, looks at treatment exposure in the trial against outcome, and basically there's no difference. You get no added benefit at all from giving a longer as opposed to a briefer intervention. Likewise, if you look at trials that compare a more intensive intervention with a less intensive intervention, again, that more intensive intervention gives you no added gain compared to a brief intervention. So your advice can just be brief. And of course, it's much easier to ask people to do something brief than to ask them to do something long and intensive. Also, the type of advice really can just be brief advice. This is a systematic review published by Platt and others that compared, for example, the impact of brief advice compared to motivational interviewing and more intensive motivational interviewing. And basically, brief advice was as good as, if not better than, motivational interviewing. So you don't need complicated types of advice. Simple advice is all that you need. The setting was also interesting. The setting that had the greatest impact was primary healthcare settings as opposed to accident and emergency settings and other settings. I think I skipped a slide. No, I didn't. Somewhere I did. Yeah, here it is. The profession of the provider. Again, in the same review, that physicians and nurses were the professions that seemed to have the best outcome compared to any other professional groups that had been studied in brief intervention studies. What these didn't do, of course, many of these studies, is compare or look at digital interventions, which is the big vogue at the moment. Eileen again I don't know how she manages to do all this, but she again did another systematic review looking at the impact of digital interventions and showed that digital-based interventions were effective in reducing alcohol consumption on average by about 23 grams alcohol per week in an intervention group with a digital intervention compared with a control. I think the real challenge, though, is how do we marry these two together? How do we link what a primary healthcare person is doing with a digital intervention? In our European ODIN study, we tried to do that, but we failed. We weren't able to link those together, and I think that's an interesting research area. Okay, I said I was going to get rid of the RT in what I'm calling MBART. Here's the audit, the full audit instrument. It says at the bottom, if you're in zone 4 with an audit score of 20 and above, you should be referred to a specialist for diagnostic evaluation and treatment. I asked the question, why? In the Royal College of GPs report, it said the overall aim was to establish a plan or protocol for finding out about every patient's alcohol consumption, for recording and assessing that information, and for acting upon it so as to reduce the health risk for as many patients as is practical. It said that the majority of heavy drinkers and patients with alcohol problems can be helped by support from members of the primary healthcare team. However, there are some patients whose care will need to be shared, those with severe medical and psychological problems, those that lack a supportive family, and where care provided by the primary healthcare people has previously failed. It also mentioned that not everyone can be helped adequately in general practice. For example, people with severe intoxication and detoxification that cannot be safely done at home would need referral. People with liver disease would need referral. People with suicide risk may well need referral. But the main thrust of this whole report is that referral to treatment is the exception rather than the rule, and is not a dichotomous entity at all. So I'd argue we only need MBA, measurement and brief advice. In any case, the R does not work. This was a meta-analysis looking at the efficacy of brief alcohol interventions in referring people to higher levels of alcohol-related care. And if we look at the overall effect, really there was no evidence that people in primary healthcare were being referred or able to be referred to specialist care. In any case, for the same type of treatment, for the same type of patient, treatment in specialist care is no better than treatment in primary care. This is your studies, Sven, plus colleagues. And this looks at the weekly alcohol consumption for 288 Swedish adults who fulfilled ICD-10 criteria for alcohol dependence. They were randomly allocated to treatment in primary care or specialist care, and basically you can see at 6-month follow-up there was no evidence that those who were referred to specialist care did better than those that got their management in primary care. And here's another study that was looking at 304 United States veterans with a low audit C cutoff score, and the outcome was the percent of the previous 28 days that had heavy drinking, and it compared for the same type of patient those that had usual care in primary care, the blue, and those that had specialist care in primary care, the orange. And again, there was no difference in outcome between these two interventions. So simplifying 4, only short, simple advice is needed, preferably delivered by a nurse or physician, preferably in primary health care. Sharing care with specialist services is the exception rather than the norm, and not determined by dichotomous decision-making. So we come on to the 5th and final part of the presentation, the need to provide community support to community agents. This was a book published in 1978 called Responding to Drinking Problems in the United Kingdom. This was what was called the Maudsley Alcohol Pilot Project. In my view, it's probably one of the most important studies and certainly one of the most important publications in the whole of the field that we are doing. And it certainly has driven a lot of the thinking subsequently, at least in the United Kingdom, about the involvement of primary healthcare. They coined the term community agents, which was primary healthcare physicians, primary healthcare nurses, social workers, and others. They developed and demonstrated the model that training of these community agents led to improved role security and therapeutic commitment in working with people with drinking problems. Those people that had improved attitudes managed more patients with their drinking, which in turn led to a further improvement in beneficial attitudes, which in turn led to more patients managed for drinking. So you've got training, better attitudes, better on-the-job experience, more patients managed. And in fact, we also confirmed that model in our European ODIN project. Oh dear. Here we go. They also stressed the need for community-based support of the role of the primary healthcare agents, as did the Royal College of GPs report. And this culminated, in fact, in the WHO Phase 4 study that Nick Heather was the principal investigator, and quite a few people, I think, in this room were involved in. This study concluded that it's important to reframe views about alcohol away from a view of alcoholism to a broader understanding of alcohol problems, that this is essential for both professionals and for the public. The second important thing is that the establishment of a lead organization is essential, gathering endorsements from a range of organizations and individuals that are highly relevant to the aims of the work. And in fact, this is what we're doing in our SCALA project that Tony mentioned briefly before. This is an implementation study in 3 countries, in Colombia, in Mexico, and in Peru. And we have a model where we have a whole range of adoption mechanisms and a whole range of support systems at the municipal level to help primary healthcare workers be involved in that work. The basic design is that in each of the 3 countries, there is a municipal area, municipal jurisdiction that is in the scale-up city and a municipal area that is in the non-scale-up. And those in the scale-up get ongoing, the physicians and nurses get ongoing training and support and a whole range of community support mechanisms to support them in their work. Whereas in the control interventions, it's essentially business as usual. We've got Augusto and Juliana sitting in the audience over there from Colombia. If you want to know anything about this study and really how to do it, they're the 2 people to talk with. A huge experience of what this actually means and what this actually involves. Okay, one thing I want to mention is that what we don't have in this field is studies that demonstrate the impact at the community level of scaled-up screening, measurement and brief advice programs. We've got lots of models. Jürgen gave us models. This is the OECD model, but these are all models. They're not actual real data of what might happen. But we do have the opportunity of doing something about that, and Leo Pass, who's sitting here, is in the ideal position. He's implementing a study in Belgium that has 3 city sites, and these are all small cities. So essentially, he's more or less going to capture all of the population of adults in those cities. In one city, the providers get training and community support. In the other city, they just get training, and in a control city, it's business as usual. Now, all that Leo needs to do is get a pair of rubber gloves, a bucket, $30, which is the cost of the test. Whoops. Go to a wastewater collection place, fill up his bucket with sewage, and measure ethyl sulfate, because that is a really good metabolite that is a very good indicator of alcohol consumption. And just to show you how powerful this can be, this is a study that was undertaken in 9 different cities of the world, and this just shows the changes in the ethyl sulfite concentrations by the days of the week. And you see, you get, as what you might expect, peak levels at the weekend, so there's increased drinking going on at the weekend. So this is a very powerful, easy way of measuring an impact at a community level. So, by adding one thing, which is the 5th point, is the need for community support for community agents, and we can evaluate community outcomes with a bucket of wastewater. So in summary, there are no dichotomies, no disorders, no diseases, only continua of alcohol use and continua of the harm done by alcohol use. Alcohol is the risk factor. It's not the harmful use of alcohol or the unhealthy use of alcohol. There is no level of consumption that is risk-free. Beyond about 50 grams of alcohol a day, nearly 5 years of life are lost if you continue to drink at that level. We are measuring consumption of alcohol, we are not screening, and based on evidence from randomized control trials, an appropriate threshold for advice is an audit C level or score of 8 for both men and women, equivalent to about 45 grams of alcohol a day. Simple, short advice to cut down drinking is all that is needed to have an impact. The care of some patients will need to be shared. Referral for treatment, though, is not the norm and is not a dichotomous decision based on a score. Thus, I would argue the acronym MBA, Measure and Brief Advice. Community agents undertake MBA. They need community support. They can't do it alone, and they shouldn't be left alone to do it. We need research to study the impact of MBA at the community level. There are opportunities to do this. Wastewater analyses of ethyl sulfite provide an objective outcome measure. I started my presentation saying that we'd examine this report. What does it say for us today? I think still many lessons. Thank you for your attention.
Thank you, Peter. I said you were a bit revolutionary, and I think you showed it. I'm considering closing our addictions unit. We have time for a few questions. So Richard was the first one to raise the hand. Up front here. And I have Nicholas, Jürgen. Okay. I would like to ask all the people, please be as short as possible in your questions so that we can take as many as possible.
Thank you. Richard Sates from Boston. Thanks, Peter. I love when paradigms get changed, so thanks for that. I completely agree that the risk factor is continuous. Right? And it's the same for high blood pressure. Same for blood pressure. Sorry, I said high. That's dichotomous, right? So it's same for blood pressure, glucose level, cholesterol level. But for implementation purposes, I see that even you went from number one was it's continuous. It's not dichotomous. But number 3 was 45 grams. Yes, no for advice. And when we talk to clinicians, we have them screen by testing the blood pressure, and then if it's a certain level or above, we give advice. The same for glucose, the same for cholesterol, and apparently, according to your recommendations, the same for alcohol. So can you help me reconcile this idea of continuous versus dichotomous?
I would argue that this should, to some extent, be a decision of the primary healthcare team. When I worked as a general practitioner, we set in motion a program of systematically measuring and identifying all risk factors of all of our patients. Our responses were basically anyone that was quotes in a lower risk category, we would say, great, maintain that, if anything, cut down, and so on and so on. So I think you can have a response that is continuous based on different thresholds. I think if we're going to, though, ask most primary care providers to be involved in this work, it is probably simpler, maybe one does come back to this dichotomy, but it is probably simpler to have a threshold to say, here's what you need to do, take your measurement, at this level, you should give advice. I think that we should be basing my argument is that we should be basing that threshold on levels of alcohol consumption that trials have demonstrated work. But we shouldn't forget that it is a continuum, and we should also, if we're giving sort of more health promotion type advice, that's much more, everyone benefits by drinking less.
Hi, I'm Nicholas Bartisevic. I'm a family doctor here in Chile, so your presentation makes a lot of sense. Thank you very much. It's very practical. And I have a few questions because I teach medicine here in this university, and I teach my students to run the audit, and eventually I focus on the audit C because it's a more effective way to do it. But I wonder whether we should just go with grams of alcohol, which is even easier eventually than scaling the audit. Ask the 3 questions, and if you know what a standard drink is, you can come out with a reasonable end grams. And I don't know if this is another question, but maybe you can comment on the fact that here in Chile, binge drinking appears to be the most important problem rather than weekly average grams. So maybe we should really be careful about how we ask how many drinks you have per occasion, or how often you have 3 or more drinks to be in the 45 range that you are mentioning.
I mean, this was before audit had been developed, and there the measurement was quantity-frequency questions to measure alcohol consumption. You could argue that because Audit C is so commonly used, and because it does actually have that binge drinking question, one could argue that maybe it's simpler just to keep using that because people are generally used to that. I mean, but you could switch to quantity-frequency questions, bearing in mind that you might want to give different emphasis depending on the cultural patterns of drinking.
Three things. First, it is true what you said, that most of the differences in the Dawson can be explained by people with alcohol use disorders drinking higher within the categories. It is not possible that it would explain the lowest difference. It is more than possible that all of the other three categories would be explained. This is based on NESARC data. The other was NLACE data, but they're very similar, so it's halfway. Second, the problem of the Audit C score and the problem overall with heavy drinking is that there is probably a slightly overlapping two factors. One factor is the level of drinking and the other is the heavy drinking occasions. And we are currently trying to see if we can put it all on one dimension. The audit does it anyway, but the audit has not tried to psychometrically really be validated in societies which are just heavy drinking cultures of occasional drinking versus others. And I would not be sure whether we can do it only with QF in those societies. And the third point is that overall, if we stick to drinking less, there should probably be some half sentence of and avoid any heavy drinking occasions.
Any more questions apart from you want to ask a question? Okay.
Thank you very much, Director of WHO. Very interesting presentation. Of course, it's always easier to deconstruct and try to construct something. And it seems like we are heading for a paradigmic shift if your content of your presentation is valid. But one thing that struck me, why don't you go all the way out? Why do we talk about alcohol? Why do we talk about psychoactive substances? Can't we just measure consumption of liquid in your frame?
I'm sorry, Dag, I don't understand that.
The psychoactive component of alcohol seems to be irrelevant, that it's there's nothing, addiction, you can't call addiction because the psychoactive component of alcohol doesn't have any feedback loop. There's nothing to build on there. It can just be, it's the harmfulness of the toxicity or there's something here I don't understand. Where is the psychoactive part? And it doesn't play a role at all, or it's just in this continuum, because the main point is that this can be revolutionary, but it can also fit completely into exactly what the alcohol industry wants. So it's two ways this can go. And my point is the psychoactive component of alcohol makes it different from other commodities. But if everything is about the continuum, then it's again about the individual user and it's not about the substance. And that is my point. There's nothing in the substance. It's all about the user.
No, not at all. But first of all, this is not a paradigm shift. I mean, this is just simply stating what was said 30 years ago. I don't view this at all as a paradigm shift. It's a shift. The drug ethanol is carcinogen, it's teratogen, it's genotoxic, and so on and so on. I mean, we are talking about people's exposure to a toxic substance, which we want to help those people reduce that exposure to that toxic substance. One way to do that in primary healthcare settings is to measure their exposure to that substance and help them shift balance in terms of using that substance lower. I don't quite understand where the psychotropic properties come into that. I mean, any amount of alcohol, one molecule, can cause cancer. Any increase in the use of alcohol can lead to all sorts of health outcomes and reduction in death. What we're trying to do is help people reduce that. And I think the model of blood pressure is a fantastic one. The model of blood glucose levels is a fantastic one, where we're just trying to do exactly the same. If someone has high levels of blood pressure and they will benefit from reducing it, we give them advice and or treatment depending on their level of blood pressure. I don't quite capture your nuance, I'm afraid.
Thank you. Anja Bischoff, University of Lübeck in Germany. I want to support Jack here. I think what he meant was to talk about the addictive thing about alcohol. People who cannot stop drinking. Not about the physical effects of alcohol, but the addictive effects of alcohol. Where are these in your model?
Okay, the point I was trying to make is that a lot of the difficulty that people might have in reducing their consumption can be subsequent to brain damage. That brain damage having been caused by heavy drinking, and that brain damage can lead someone into further heavy drinking. But, I mean, I worked as a general practitioner, and Paul, I'm sure, would say the same thing, and Leo and all the other GPs in this room. I managed all people with drinking problems in my practice. The people with the most severe problems, I managed them all in exactly the same way. Obviously, those that had more severe problems, I spent much more time helping than those that had less severe problems. The number of people I had to refer was absolutely tiny and was mostly about safety. So it would be someone who I felt I could not safely detoxify or help detoxify at home, or someone who was so intoxicated I thought, well, this person really needs to be under supervision, or someone that has liver disease. I mean, to me, and what we said in this Royal College of General Practitioners report, for a general practitioner, the terms alcohol dependence, alcoholism, addiction were just meaningless terms. They were not useful terms. What we were there to do was to help people with alcohol problems.
Okay, we take the last question.
Thank you, Peter, for this challenge. Thank you also for adding community as a major attention, actually, to the way or the place where practice is being done and should be involved in alcohol. Thank you also for the idea of MBA, but there is a danger in that, I think. Supposedly, we only measure, and we refer to a measuring person, a digital site. There is no interaction except from go measure. So it's not the measuring which is important, it's the attention to alcohol as a topic which is important, which is the crucial thing in it. And that's not mere measurement. Okay, so that, I think, should be in our mind. So there's always an interaction about the alcohol use, independent on the level of use. And that's actually the main message, which is that we need to be aware of alcohol and we need to do something about it. Okay?
Yeah, I mean, yes. I mean, when I say measure, this is not a sort of cold calculating thing. This is a healthcare provider talking to someone about their alcohol use or asking about their alcohol use. And that very engagement is a sensitizing issue. And that's also why I said that the intervention is both the measurement and the advice. Yeah, I fully agree. And often that process is the start of a conversation.
Leo, we have to finish. We can discuss it after that. Now it's time to finish. I have to give an advice. The Special Interest Group on Digital Interventions will be meeting not in room 5 or in 6th floor as it was stated in the paper. It is meeting in Seminario 3 in the Faculty of Medicine building in the 5th floor. That's it at 12:45. And everybody is welcome to attend there. Having said that, I want to close by thanking everybody for staying here. I think we've had a very, very productive morning with high-level talks, and I want to especially thank Peter for giving us food for thought. So thank you very much.